Hello, dear colleagues. Welcome to this IPC Think Tank session. Today, we're going to talk about does systemic therapy still have place in the psoriasis treatment? These are my disclosures. When I think about conventional things, I think about like something like this old car. It seems very old, but I like it and it works. So does the same the systemic conventional therapies in psoriasis. They are very old, but they work, and they work really well in the biological era. So first of all, we are going to talk about methotrexate. Methotrexate, these are the first publications made about this medicine. As you can see, it's a really old medicine in the 1950s. It was discovered and treated at the beginning. It was effective for the treatment of childhood leukemia. It acts by inhibition of the dihydrofolate reductase, and is that this enzyme is essential for the DNA synthesis of the rapidly mitotic cells. So this is the graphic, and as you can see here, we have this inhibition of the hydrofolate reductase, and this diminishes the thymine production and therefore the DNA synthesis. But nowadays we know that methotrexate also blocks the formation of the transformylase. This is an enzyme that is essential for the purine synthesis and also inhibits the DNA synthesis. So it acts by these two mechanisms and is a very good anti-inflammatory medication. This was the consensus made in the 2022 and published by a big group of dermatologists worldwide. We had the opportunity to participate, and this shows which is the best way to manage methotrexate. So I'm going to show you what I think is the best option on prescribing this medicine. First of all, about the dose. You have to start minimum of 15 milligrams per week or increase rapidly to 50 milligrams per week. This leads to a greater improvement in the PASI 75 compared to 7.5 milligrams per week dose. This dose has a faster onset of action compared to lower doses. So nowadays we know that we have to use these high doses to achieve a rapid and better outcome in the past. This study shows us why 25 milligrams is a better dose than 10 milligrams from week 10. And this shows how the PASI improves very, very quickly, better in the 25 milligram compared to the 10 milligram dose of methotrexate. The maximum dose weekly is 25 milligrams. After that dose, it has no anti-inflammatory effect. About the delivery mode, we know that the subcutaneous route is better than oral route because it has increased bioavailability and has less adverse events related to oral administration. So patients maybe are more adherent to these treatments via subcutaneous way because they have less adverse events. And these two studies, different studies, shows us how the subcutaneous route gives us a very linear absorption of methotrexate versus the oral methotrexate. When you take oral methotrexate, you have to increase dose, and after maybe 20 milligrams, the receptors in the gastrointestinal tract get saturated and it doesn't get absorbed the methotrexate. So it's important and better to understand that if you have the possibility to use subcutaneous methotrexate, is a better way of administration of this medication to achieve your PASI goals in your patients. About special considerations, in pregnancy, this X category is contraindicated. Breastfeeding also contraindicated. You can use it in oncologic patients, and you can use it in geriatric patients, but you have to be aware that you have to make dose adjustments, lowering doses, because in elderly patients, we can have slowly clearance of methotrexate. So you have to use lower doses. About interactions, myelosuppression could be one of these secondary effects. Leukopenia and thrombocytopenia are the most frequent, and they are seen at any time, but more frequently between 7 and 10 days after initiation. So you have to take basal exams before initiation of methotrexate, and in the first month you have to take control of these exams to evaluate for myelosuppression, for example. And about transaminase, you have to take basal transaminase before initiation of methotrexate, and if at the control, preferably after 1 month, if the methotrexate increases more than 2 times at the basal levels, you have to indicate suspension of therapy. Nowadays, hepatic biopsies are not recommended. More likely, it's more recommended the hepatic elastography, but we know that methotrexate is a very safe medicine, and when you make annual monitoring of doses, you can use methotrexate in the long term safely. This study shows about hepatic consideration. For example, how is a very low percentage of patients who has liver test abnormalities. You can see them, but this is a not great percentage of patients. It's important to remember always before initiation of treatment with methotrexate basal exams, and after the first month, you have to do another round of exams to examine if transaminase go to 2 times the basal level and indicate suspension of this medicine. About interactions and secondary effects also, in patients with HIV is recommended, requires monitoring. In hepatitis B or C, it's not recommended for obvious reasons. In patients with tuberculosis, the evidence of reactivation of latent tuberculosis is really, really low, but the screening for latent tuberculosis, more importantly in Latin American countries, or countries when you have a high incidence of this secondary effect, is important. Patients with positive TB test should be treated. Vaccination, it's not recommended until 3 months after application with live vaccines, but the other vaccines, you can use them safely. 50% of patients have interactions to polymedications with non-steroidal anti-inflammatory drugs or sulfonamides. It increases risk of pulmonary, renal, and gastrointestinal effects. This is a chart, a really nice chart that shows us these interactions, and I wanted to show you that ethanol is a medicine in the alcoholic beverages that you should avoid when you are treating patients, that you tell your patients that should avoid alcoholic beverage during the treatment of methotrexate. This study showed us for the first time, for example, how patients can achieve higher PASIs, such as PASI 90 or PGA 0 to 1 with treatment with subcutaneous methotrexate. So it's important to note that these medicines really work in psoriasis patients. About cyclosporine, this is the chemical structure. It comes from yeast, Tolypocladium inflatum. It inhibits the phosphatase of the calcineurin calmodulin complex. and inhibits NFAT translocation, so inhibits the production of IL-2 and interferon gamma. About the pharmacology, different brands should not be used. Hydrophilic emulsion elevate drug levels. Dosage accordingly, weight 2.5 to 5 milligrams per kilo, dividing in two doses at the same time. Take before meals with milk or orange juice because this increases absorption, and avoid taking with groups because inhibition of the cytochrome P450 and you shouldn't take with grape juice cyclosporin. This is very important. You should tell your patients this. Drugs, it's the drug of choice in exacerbation due its rapid onset of action. It's really, really quick in onset of action. Decreases the doses if you have to decrease the dose if control is achieved, and you have to use it for short periods of time, maximum 1 year. This chart shows us what about renal function. So if you increase serum creatinine 30% above baseline, you should repeat measurement, and if it reduces, you can continue cyclosporin without any issues, and if it remains increased in more than 30%, you should stop cyclosporin. About arterial hypertension, if blood pressure is elevated or increases up 140 systolic or 90 millimeters diastolic, you should repeat measurements after 2 weeks. And if it persists, you can treat hypertension or stop or reduce doses of cyclosporin. So in hypertension patients, it's contraindicated, but if you elevate your blood pressure, my recommendation should be to stop cyclosporin. It's recommended to screen for latent tuberculosis, HIV, and hepatitis. As with methotrexate, you can not use live agent vaccines while on cephalosporin, and interactions with NSAIDs and medicine with CP450 metabolism, they decrease kidney function. Aminoglycosides, ciprofloxacin, fibrates, and azoles, they are nephrotoxic, so you should avoid treatment with these medicines when you're on cyclosporin, and you have to stop. You cannot use tetracyclines because they increase risk of pseudotumor cerebral. Side effects: gingival hyperplasia. This is the most common. This is because of inadequate oral hygiene. You have to counsel your patient to do regular visits every 6 months. Results with metronidazole treatment, and this is due to poorer oral hygiene. So you have to insist your patient to take care of their mouth. And finally, acitretin. This is a vitamin A systemic retinoid. It works on the modulation and proliferation of differentiation of the epidermis, and it has immunomodulatory and anti-inflammatory effects, decreasing VEGF, inhibition of the Th17 response also. Its daily dose is between 30 and 40 milligrams. It has a very, very slow onset of action between 3 and 6 months, and it reaches PASI 75 between 30 and 50% of patients. So it's a very, very slowly treatment. It has its specific indications such as general pustular psoriasis and palmoplantar psoriasis. It's recommended to take with fatty milks or whole milk. Advantages: it's not immunosuppressive agent, so it can be used in HIV patients or immunocompromised patients. But the contrasts are that it gives a lot of xeroxtomia, xerophthalmia, xerodermia, dyslipidemia, or impaired cicatrization. Pregnancy is completely contraindicated you have to counsel your patient to make contraception 3 years after taking it and not donate blood 3 years after taking a 16. So I think it's a very limited medication, but in very specific patients you can use it. So this was everything I had to tell you. Thank you so much for your attention.